Like we mentioned earlier, that anticoagulants are less useful in preventing arterial thrombosis because there is faster flow of blood in arteries, so the thrombi are composed mainly of platelets with little fibrin. In this case, antiplatelet drugs come into play to reduce platelet aggregation and arterial thrombosis. In apherematous arteries, the plaques most likely to rupture possess a large lipid-rich core covered by a thin fibrous cap. Rupture of the cap exposes subendothelial collagen that activates platelets and causes aggregation. The key event in platelet activation and aggregation is an increase in cytoplasmic calcium. This causes a conformational change of the inactive GP2B3 receptors on the plasma membrane to receptors with a high affinity for fibrinogen, which forms cross-links between the platelets and hence aggregation. This releases thromboxane A2, adenosine diphosphate, and 5-hydroxytryptamine, 5-HT, which promote further platelet aggregation, vasoconstriction, and activation of the clotting cascade. Thromboxane A2, thrombin, and 5-HT activate phospholipase C, and the resulting inositol 1,4,5-trisphosphate stimulates calcium release from the endoplasmic reticulum. ADP inhibits adenylyl cyclase, and the decrease in cyclic adenosine monophosphate again increases cytoplasmic calcium. All antiplatelet drugs act one way or another to inhibit these calcium-dependent pathways of platelet activation. So, now moving on to the first antiplatelet drug, that is aspirin. The beneficial effects of aspirin in thromboembolic disease are brought about by the inhibition of platelet thromboxane A2 synthesis by irreversibly inhibiting cyclooxygenase, or COX enzyme. Thromboxane A2 is a powerful inducer of platelet aggregation. The endothelial cells of the vascular wall produce a prostaglandin, prostacyclin, which may be the physiological antagonist of thromboxane A2. Prostacyclin stimulates different receptors on the platelet and activates adenylyl cyclase. The resulting increase in cyclic AMP is associated with a decrease in intracellular calcium and inhibition of platelet aggregation. Platelets cannot synthesize new enzyme, but the vascular endothelial cells can, and a low dose of aspirin, usually 75 to 300 milligrams, given daily produces a selective inhibition of cyclooxygenase over much of the dose interval. Thus, the balance of the anti-aggregatory effects of prostacyclin and the pro-aggregatory effects of thromboxane A2 is shifted in a beneficial direction. Next, we have clopidogrel, a thienopyridine derivative, reduces aggregation by irreversibly blocking the effects of a DP on platelets, thus resulting in CAMP levels with decrease in intracellular calcium and inhibition of platelet aggregation. It has a synergistic action when given with aspirin. Clopidogrel is also used in patients in whom aspirin is contraindicated. Prasugrel and ticagrelor are other ADP inhibitors acting on P2Y12 receptors. They are also used in patients with acute coronary syndromes who are to be treated by percutaneous coronary intervention. Eptifibatide, tirafibin, and ivsiximab, a monoclonal antibody, inhibit platelet aggregation by binding to the glycoprotein 2B3A receptors. They are given by intravenous infusion together with aspirin and heparin to prevent myocardial infarction in high-risk patients with unstable angina awaiting percutaneous coronary intervention. Dipyridamole is also an antiplatelet drug used with warfarin to prevent thrombosis formation on prosthetic heart valves, although there is doubt of its efficacy. It is thought to reduce platelet aggregation by increasing cyclic AMP levels. It is actually a phosphodiesterase inhibitor, but may stimulate adenylyl cyclase. Remember that antiplatelet drugs, especially aspirin, have been shown to reduce the risk of myocardial infarction in patients with unstable angina, increase the survival of patients who have had myocardial infarction, and reduce the risk of stroke in patients with transient ischemic attacks.